How did you come into this role?
So I was trained as a specialist paramedic in the ambulance service, and part of that there was a primary care placement, and that's how I was first introduced to the surgery that I now work for. I now work at this surgery 3 days a week, and I work a day a week for our primary care network now as well.
The primary care Des, what is it actually that you're expected to be doing as part of that?
My main surgery, we have 4 care homes. So over my 3 days that I work there, I have their set days and review them by telephone with the managers. So that's our weekly ward round, which is me and the care homes. And then I review anyone face to face that I need to. But equally, I can contact, the GP or a member of the MDT, such as a geriatrician, if I need more acute advice. And then our actual full MDT meetings, we're having every 6 weekly, with just selected patients that we've struggled with or need that full MDT support with. And that's then a geriatrician, a complex care and dementia psychiatrist, a social worker, the GPs, me, and the care home managers. And we've come up with a method of ensuring confidentiality between the care homes. But I think it was quite important that they all dial in and listen, because I think there's lots of learning.
What would you say are some of the things that helps the MDT work?
Having one person to organise it, make sure it's going to happen, circulate names and profiles before the meeting, and then feeding back and actioning any points. And I think having them 6 weekly and via Microsoft Teams now, it's not too burdensome for the experts that are joining us. And they've got the time to help us.
So that's really an example of digital technology helping and improving ways of working, would you say?
Definitely. And on the weekly reviews, using AccuRix to video call where we need to, and not necessarily having to go, especially in the COVID world, that's really helped.
How much are you able to kind of bring in the whole idea of personalised care and what matters to the individual beyond just the clinical needs?
So because it's me, I get to know I get to know all the patients. Whenever someone new moves in, I do an individual review. I have a good relationship and contact with families. I find the time to talk to them, especially when they move in, and introduce my role, and let them know that I'm here and to contact me at the surgery if they need to, as well as through the care home. So I think that's the real benefit in me always doing the weekly reviews as the same person, and getting to know them really well, and what they're like and what their wishes are, and seeing early that any deterioration so that we can plan for that, and recognising early. I had a complicated Alzheimer's lady who has epilepsy, and I needed some geriatric input into her medications as she was over sedated, and having the email contact for our geriatrician, she really quickly provided advice. So that problem is now solved, and it shouldn't need to come to the MDT, but if we do have ongoing problems, we can bring it to the MDT.
So what would the process have been before you had these MDT meetings in place?
Written referrals back to secondary care, or written referrals to the complex care and dementia team, which is a slower process.
What barriers or what issues or difficulties have you come across in MDT working together as a multidisciplinary team?
The biggest at the minute is that the complex care and dementia team have not been realigned to our PCN. So the person that joins our team covers the bulk of our homes, but he doesn't cover the nursing home. And we've thought about having physios and OTs and maybe dietitians join our team. We're struggling for contacts at the minute, but I think having had a few meetings, probably what we need is these people to contact on an ad hoc basis, and not necessarily join every meeting, having seen the sort of patients that we bring up at the meetings.
What's the kind of the GP involvement?
So whenever I need, after my weekly reviews or visits, I can always talk to the GPs. Obviously, I still need their input for end-of-life care. And then the MDT meeting, the lead GP for the care homes from each surgery joins the MDT meetings. They've got an overall picture of what's going on.
Anything else that you think would help?
I think starting small. You don't have to have everything up and running. And actually, I've seen things just develop and more people show interest and hear about the MDT and ask to join. For us, it was just setting a date to work towards. So we had that date set and we had to do something that day, and that really helped just to get up and running. And I think thinking about the people that can help deliver this, other allied health professionals and nurses, I think can really help deliver this if GP surgeries are struggling. Our interpretation of the weekly reviews with me and the care home is really supporting the homes and doing what we need to do, and ultimately delivering the best care to those patients, and then utilising the MDT at 6 weekly is a really good use of time. And at our surgeries, we wouldn't feel like a weekly full MDT would be needed or the best use of our experts' time.